From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to this author interview from the JAMA Network. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology. And today we're going to look at a fascinating topic, patching in children who had unilateral congenital cataract and child functioning and parenting stress. Joining me is the professor and chair of the Department of Global and Community Health within the College of Public Health at George Mason University in Virginia, Dr. Carolyn Drews-Botsch. Dr. Botsch is the lead author in this article, and we're thrilled to have you join us today. So, Carrie, thanks for sharing your information on this.
Thank you so much. I'm really excited to be here and to talk about this work.
Great. Well, maybe you can just tell me a little bit of what made you and your group want to look into child functioning, parental stress that might occur with patching. I mean, not everyone in the world has had children where they are having to patch them, perhaps to try to prevent amblyopia. What made your group want to look into this in patients who had unilateral congenital cataracts and then needed patching?
It's a really interesting problem, and I've come at this both as a parent as well as an epidemiologist. And that is that we started working on this issue of how best to treat children with unilateral congenital cataracts. Sort of going back a while, there was originally, prior to about the 1970s, the idea that children who were born with a cataract in one eye really didn't have a lot of hope for getting any vision in that eye. So they could probably see fine out of the other eye, but the eye that had the cataract, even if you took it out, really didn't have a lot of hope for good vision.
When they took the cataract out, or when they take the cataracts out now when they're unilateral, when do you typically start patching to try to prevent amblyopia?
It's relatively soon after the cataract is out. I think within the first 2 weeks after the cataracts are removed. And these babies have the cataract surgery sometime between 28 days and 6 months of age. So they're really young, and they start being patched very young as well. So they're being patched when they're still infants. And the patching really is expected to continue through about age 6 in most of these kids to try and make sure that they have the opportunity to really use the eye that the cataract was in and develop the vision in that eye.
And share with us what you and your investigators have learned over the years regarding parents' concern about this patching. Did you think that they might have stress in the family or their interactions with their children when they need to put this patch on every day?
Patching is hard. It's hard for parents, and the kids don't like it. You're putting something over their eye and over their eye that sees better than the other one. And particularly for the kids in the study that we looked at, we really focused on children who did not have good vision at all in their treated eye. And so when they're wearing the patch, they're wearing it over the eye that is their fellow eye or the one that did not have the cataract. So you're taking a child who is running around and seeing fine, and you're putting something on their face and making them not see very well. So there's a lot of anecdotal evidence and discussion about how difficult it is for parents to patch, how stressful it is to try and maintain the patch. Really, from the start of the time that we studied this particular group of babies, we were interested in trying to understand this. I had a particular focus and interest in this because I had a child who had a feeding tube. And so, I knew what it was like to deal with a child who has some extra thing going on that you got to deal with when they're a baby. It does sort of potentially change the interaction and change how the child feels about themselves.
I think so many parents probably can relate to that, and so many of our healthcare providers as well. So tell me, what was the main outcome you were looking at in terms of determining the child's function or the parental stress?
So we looked at parenting stress in 2 ways. One, using a generic, any kind of condition stress scale, which was called the Parenting Stress Index. And that we measured on those kids when they were 4.5, so just about before they're starting kindergarten, and then when they were 10.5. And then we had our own scale that we developed, which really dealt specifically with taking care of a child with an eye condition called the Ocular Treatment Index. We looked at motor functioning at age 4.5 using a standard scale called the Movement Assessment Battery for Children, or Movement ABC, which has things like the child is supposed to hop or throw a ball. And we also looked at child behavior problems using a standard scale called the Child Behavior Checklist. CBCL, the standard scale of reported behavior problems. And then at age 10.5, we asked the kids how they felt about themselves using another standard measure called the Harder Self-Perception Profile.
So this is amazing that you actually had the same cohort of children followed for up to 10 years. Where did these participants come from? I understand this was from the infant aphakia treatment study, people that participated in that study. But what was that study all about?
So that study, the infant aphakia treatment study, was a randomized control trial of children who were born with congenital cataracts. And so what a randomized control trial is when there are two different treatments and children are randomized. Half of them received the standard treatment, which in little kids is to take the cataract out, and then the child no longer has a lens in their eye, so then they have to wear a contact lens over that eye to make sure that they can still focus, or whether to put an intraocular lens in when they take the cataract out, which is what they do with most adults and older people who have a cataract. They put a lens in, sort of a plastic lens in place where the natural lens would be. So that was the real start of this study, was to see whether or not either of those treatments was better in terms of producing vision. Basically, what we found was that the vision was the same regardless of which of those two treatments that you used. There were some extra complications because the surgery is a little more complicated for putting the IOL in. And so we have recommended that most kids have the lens taken out and then be treated with a contact lens for at least the first couple of years.
So you have this cohort, at least who had a unilateral congenital cataract, had this treated in one of two ways. You learned that it probably was not superior to manage the aphakia one way or the other, but now they all need patching. And so you looked at this stress that either the parents have or the functioning that the child has. So tell me, what did you find in the short and long term?
We limited our analysis to kids with bad vision in that treated eye. So we were trying to take the worst case scenario. So these are kids who had vision of 2200 or worse in their treated eye. So they really don't see well when they're wearing the patch. We found actually that there were no differences that we could tell between the children who were not wearing their patch at all when they were 3 years old, compared to those who were wearing the patch at least 2 hours a day. The kids are all supposed to be wearing the patch about 50% of waking hours, which would be more like 5 or 6 hours a day. So there were relatively few kids who continued to be patching at that really high level. So everybody kind of reduced. But we really didn't see worse outcomes or more stress in the kids who the parents had sort of given up on patching and those who were continuing to try. I think that is a pretty surprising outcome. Most people, including us, expected that those parents who were still trying to patch would be more stressed than those who weren't. But I think it's good news for parents and healthcare providers that they can say, yeah, this is hard. We know this is hard, but it's not hurting your child to do this kind of patching.
So this must be great relief to be armed with this new information and at least allow parents to consider this when there may be such stress otherwise. Thinking about Do I want to patch my child? Is this really going to help? Especially in the ones who didn't see well. Was this known before, or this is really new guidance for people to take into consideration?
I think it's really new information. It doesn't change the guidance. One of the co-authors on this paper, Jeannie Hartman, often talks about whether you're raising a child or raising an eye. What this work really says is that if it's true, and we believed it to be true, but if it's true, then you don't have to make the choice between doing what might be best for the eye versus what might be best for the child and the family. And so I think that that is really reassuring.
Yeah, I think that's so important. Now, you mentioned that this was in a subgroup of the entire cohort that actually had poor vision. Do you think this applies to those who may also have good vision? I would suspect there are some parents that, despite the fact that their child has good vision, have a little stress, perhaps, or might be worried about having stress from doing the patching, even in those cases, maybe to keep up the good vision. So should we extrapolate to those groups, or does this need to be evaluated further?
I think it needs to be evaluated a little further. We did look at it. One concern that we had was that among the kids who have good vision in that treated eye, for example, 20/40 or better, there are relatively few of those parents who aren't patching their child at all. So we really didn't have very many numbers in order to look. But to the extent that we could, we really didn't see worse outcomes in those parents who were continuing to patch 2 hours a day or more.
Any next steps in the near future in terms of what you found or what you might do next?
The other question is, particularly in this group of kids with poor vision, so if patching doesn't do any harm, that's great, but is it actually doing any good? And I think that's the next question that we're really looking at, is to see whether or not, once you can get a reasonable estimate of what the vision is in a child, like around age 3, is the vision sort of set and we shouldn't continue to patch these children who have vision of 2200 or worse. We suspect now that it's not doing any harm, but is it actually doing any good? So I think that's really our next question.
Well, I'm so appreciative that you were able to share this with us today. We've been speaking with Dr. Carolyn Drews-Botsch, who is the professor and chair of the Department of Global and Community Health in the College of Public Health at George Mason University. And she was discussing some evaluations of participants who had been in the infant aphakia treatment study and looking at patching in those children who had unilateral congenital cataract with poor vision to see what the child functioning was and what the parenting stress was as well. Carrie, I cannot thank you enough for sharing your personal story interest in this, as well as the science that you shared with all of us that I think will be very helpful, not only to the patients and their parents, but to all the investigators who are looking into the challenges of congenital cataract in pediatric ophthalmology. Thank you so much for joining us today.
Well, thank you for the opportunity to talk about this work.
This episode was produced by Shelley Steffens at the JAMA Network. And to follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. I'm Neil Bressler, editor-in-chief of JAMA Ophthalmology, and thank you all for listening.